Vesicoureteric reflux means it is ureter is implanted into the bladder in oblique fashion normally, but when it is in straight way, mucosal fold guarding the ureter and it's little bit of defective. Mucosal bulb is defective. You have urine flowing back into the ureter and kidney, back pressure, extravasation, and recurrent urinary tract infection, pressure damage. So thereby, these are the way mechanism where you have renal damage. So recurrent urinary tract infection. So until 5 to 10% of these cases has the disease progression, and 10 to 15% of this VUR has an episodic acute pyelonephritis, leading to the CKD progression. Thereby, they are to be treated. When to treat? Normally, the intramural part of the ureter is zero point 0.5 centimeter in the neonate and 1.3 centimeter in the adult. In between, it is in between. So when the child grows, the ureteric muscle strengthens and adrenergic tone increases, and the child grows in length. So thereby, 15% annual reduction rate of the vesicoureteric reflux. So we can wait for 6 to 10 years, but in the high grade reflux, difficult to wait. At times, you need to intervene by the three modalities of treatment. One is the medical treatment, that is prophylaxis, antibiotic prophylaxis to prevent urinary tract infection. The low dose, one fourth of the standard antibiotic given at single dose, maybe BD. So for 6 months or longer and to prevent infection, but they may not be useful at all always. So there can be breakthrough infection. And second option is this, the surgery means deflux injection or this ureteric reimplantation. They are needed mostly when there is non-compliance, non-adherence to medications, and when there is the patient's preference, parents' preference is there. So those cases are to be treated in two way. One is the injection of the endox endo 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 endotox endox and deflux injection by endoscopic means, and few more these closer agents are being used currently. So followed by the they are followed by the your antibiotic prophylaxis. And surgery means reimplantation, that is making a flap guard and putting the ureter in the oblique fashion. So whatever the surgery you do, you need to go for antibiotic prophylaxis and for lifelong follow-up. So another one is the circumcision. So in grade 5 reflux, circumcision has definite benefit. The periurethral flora grown over here invades into the ureter, bladder, and you are ultimately to kidney. So they are less, thereby you have less urinary infection. It's beneficial. Whatever you do, lifelong follow-up of these cases for urinary tract infection and CKD progression.